Hello and welcome everyone to today's session of Surgery Online. Thank you all for joining from around the world to this very exciting program that we have today for you. Indeed, we have a huge program, so you will see in total 5 different surgeries by 2 very renowned surgeons. But before I will let you know about the details, I would like to ask you for a little bit of support from your side. Please do name yourself correctly. If you haven't entered your correct name in Zoom already, please do that by right-clicking. Oh, sorry. So by clicking on the right of that of the participant panel and choose rename, and please enter your full name there. To avoid background noise, I would ask you to please mute yourself and only to unmute yourself if you want to say something. And also for a stable internet connection, we always recommend to close any programs that might run in the back, such as MS Teams or Outlook and so on. Like this, you can guarantee that you really benefit from the fullest from today's programs. Please always feel free to type your questions and comments in the chat. We will go into the questions and start a discussion after the cases, and I am really looking forward to that. Okay. Enough from my side. I want to introduce today's surgeon. So we are really happy to have Professor Dazert with us, who is from the ENT Universitätsklinikum in Bochum, Germany, and Professor Piotr Skarzynski from the World Hearing Center in Kajetany, Poland. So Professor Dazert will start, and he will show us 3 different cases, namely 2 tympanoplasties and 1 Stapes surgery. He will use the 2 MED-EL length adjustable prosthesis, namely for the first surgery, the MED-EL Pro partial prosthesis, and for the second one, the MED-EL Pro total prosthesis. For the Stapes surgery, he will use the MED-EL Stapes prosthesis. Then we will see Professor Piotr Skarzynski, who will show us 2 Stapes surgeries, both of them with the MED-SEM Stapes prosthesis, and he will show us a little how he does it and tell us a little tips and tricks about how he does his Stapes surgery. And with this, I really want to hand over immediately to Professor Dazert, because we don't want to lose any time, and give the stage to the surgeons. Thank you, Professor Dazert, for joining and for sharing your experience with us. Thank you.
Thank you very much, Leni, for the kind introduction, and good afternoon and hello to everybody also from my side. As mentioned already, we want to speak today about ossicular reconstruction and Stapes surgery, and we also want to present MED-EL's new passive middle ear implants and show you a few available prostheses in this field. I would like to start with partial and total prostheses for ossicular reconstruction, and I will focus a little on the MED-EL Pro kit, which provides the surgeon with variable length prosthesis. That means that the surgeon intraoperatively is able to adapt the length of the prosthesis to the patient needs. And I will show you in a few minutes how that works. So the first case I would like to present is a tympano revision surgery, a patient with a chronic otitis media, and he had surgery many years ago. So the primary surgery is several years ago, and he got a reconstruction of a tympanic membrane defect using a cartilage underlay technique. And nowadays he presented with conductive hearing loss of about 30 to 40 dB, and that was the reason for revision surgery for us. So when we opened the ear, we found that the tympanic membrane reconstruction was intact, but the incus and the malleus was fixed. So we opened the incudostapedial joint, removed the incus, removed the head of the malleus, and then we found that the head of the stapes, or the stapes itself, was mobile, and we had to think about ossicular reconstruction. And I would like to ask for the first video now, please. So this is a left ear, as you can see. This is the reconstructed eardrum. This is the head of the stapes. Tympanic membrane is intact, promontory, chorda, facial nerve is down there, stapes is mobile. Now we go to the Pro kit and choose Sison, a dummy prosthesis, which is placed between the stapes and the tympanic membrane to estimate the length of the prosthesis. So energy transmission seems to be okay with this length. Then we remove the sizer and go back to the sizer kit. It's a 2.5 partial prosthesis in this case. And here you see the prosthesis itself. And in this system, the length of the prosthesis can be adapted with the instrument to the measure 2.5 millimeters, as shown here. We then fix this situation by closing the head plate, in this case with a 5 millimeter alligator. Now it's closed, it clicks in, you can feel it and you can hear it. And finally, the titanium stick that is not needed anymore will be cut off with a knife number 15. And at the end of the procedure, we have to remove the fixation device with a forceps like this. And then we end up with a partial prosthesis of 2.5 millimeters that is ready for implantation. And we then place it into the tympanic cavity, position the little basket, the little titanium basket with this nice bell-shaped round construction here on the head of the stapes. It coincidences like a ball joint, and the head plate goes towards the tympanic membrane. And I think you can see that there is probably a nice sound transmission from the tympanic membrane to the ossicular chain and going to the inner ear. So this is the new partial M-exact prosthesis for ossicular reconstruction. The next short case I would like to present to you is a patient that had cholesteatoma surgery more than 20 years ago. And now he presented with conductive hearing loss of about 30 to 50 dB, so a little more than the last patient. And he asked for a surgery to improve his hearing. So we opened his ear again. Tympanic membrane was intact. And when we checked the tympanic cavity, we saw that the primary surgeon used the patient's incus for ossicular reconstruction. And he shaped it as a total prosthesis, so placed it on the footplate, and so between footplate and tympanic membrane. And over the years, there was a lot of scarring and also bony adhesions. So this autologous implant was a kind of fix and caused the hearing problem. So under high microscopic view, we loosened the incus implant and removed it. And the Stapes footplate showed to be mobile in this case. So again, we had to face ossicular reconstruction. And please start the video now. And I would like to show you the total M-exact prosthesis, also again with the Pro kit with a length variable prosthesis. So again, we choose a sizer, a dummy prosthesis. This is a right ear promontory, access to the round window niche. Here is the Stapes footplate. And the dummy will be placed on the footplate and will be positioned between footplate and with cartilage reconstructed tympanic membrane. We check the stability and the size, pressure, looks okay. The sizer will be then removed. It's a 4.5 millimeter sizer. And again, we go back to our workstation, so to say, and create a total prosthesis with 4.5 millimeter length. Close the head plate with the instrument and then cut off the remaining titanium stick. And the prosthesis is ready to, so to say, after removing the fixation in this tool. Now we go back to the operation site. Lift the tympanic membrane and position the prosthesis between footplate and cartilage reconstructed tympanic membrane. And what you see here is that the head plate has a nice opening where the surgeon can view the contact area of the prosthesis, in this case on the footplate. So you can direct your prosthesis to a connection point wherever you want. And you can still see where it goes and where you need to direct and maybe correct if necessary. The head plate goes towards the cartilage reconstruction in this case. And that looks like a stable position of the prosthesis and a good sound transmission in this case. So what I personally like in these M-exact prostheses is that they are easy to handle. I could show you the option that you can view through the head plate and see where the connecting part goes to, and you are able to direct it under view. And I also really like in the partial prosthesis the little connecting basket which goes on the head of the stapes. It's a nice round bell-shaped titanium construct which goes to the stapes like a ball joint and seems to adapt nicely and guarantees a good sound transmission in this case. The last case I wanted to show to you is a patient with otosclerosis, so a classical otosclerosis patient. So he has a regular tympanic membrane. In the audiogram, he showed conductive hearing loss of about 25 to 30 dB. And after talking to him about the surgery and of course about the alternative options like hearing aids, this is very important, at least in Germany, to give the patient all the additional information. We scheduled him for surgery. And in Stapes surgery, we like to apply an end-oral approach. And then we prepare the tympanomeatal flap, open the tympanic membrane. And now I can show you on that short video how the surgery proceeded. So again, it's a right ear. Please start the video now. So we open the incudus-stapedial joint after checking the mobility of the chain. Incus and malleus are mobile, the stapes is fixed. You can see cora tympani, and down there the stapedial tendon. There's the footplate where you see the reflexes. We cut the stapedial tendon with the micro scissors or with the sickle knife. And then we open the posterior crus of the stapes superstructure with a 0.4 millimeter hook, break the anterior crus, and then remove superstructure from the middle ear cavity, from the tympanic cavity. I would like to give you a view into the inside or inner part of the stapes superstructure, and you see this nice hollow grinded area. So nature made it light and stable in the same time. So I always like to see this. It's a nice aesthetical view in my possession. And now we do the stapedotomy in the posterior part of the footplate using a skitter drill, a 0.7 millimeter drill, and you see here this round opening in the posterior half of the footplate. Don't suck in this area, always a little distance. Don't suck off the perilymph. And now we grab the stapes prosthesis. The M-axis titanium prosthesis is my favorite out of the collection available, and I will show you why in a minute. We have to direct the shaft of the prosthesis into the stapedotomy, and in the same time position the loop of the prosthesis on the long process of the incus. Here you can see the wide and perforated titanium loop of this special prosthesis. I like it because you can position it nicely on the incus while placing it with the shaft down there in the stapedotomy area. And then you move it to the place you want it. And because of the perforation, you can nicely close the loop around the individual shape of the long process like this. And then we check the mobility by moving the handle of the malleus, and you can see that everything, the whole system is moving. At the end of the surgery, we seal the shaft of the prosthesis in the oval niche with little connective tissue parts. And then the ear is closed, and we leave the packing for about a week before we remove the stitches. The M-axis prosthesis is my favorite choice out of the choice of different prostheses because of the special shape of the titanium loop. And I think because of the whiteness and because of the perforation, it reduces the pressure on the long process of the stapes, which is important in my view. And it also allows and ensures a gentle crimping around the long process of the incus, which may have really different shape and different thickness, as most surgeons know who do this kind of surgery. So this is my special choice. And I'm at the end of my presentation, and we can move over to Piotr Kajetany, and he will show us his technique and his preparations of prosthesis choices. Thank you very much so far, and we will discuss and answer your questions later on. Thank you so far.
Thank you so much, Professor Dazert, for these, for sharing these interesting cases and your experience with ossicular reconstruction and Stapes surgery. To our audience, please feel free to type your questions, comments, open discussion points into the chat. As I already said in the beginning, we will be happy to start the discussion after Professor Skarzynski's presentation. And I will, like this, hand over to Professor Skarzynski, who will be also so kind to share 2 of his Stapes surgeries with us. Professor Skarzynski, please.
Yeah, hello, good afternoon. Yeah, I think it's visible now, the representation. Yes, can you see this presentation?
Perfect, thank you.
Yeah, I would like to share our experience. Of course, you know, my father is the person who performed 24,000 stapedotomies, so he is my teacher and sometimes even very tough teacher. And stapedotomy is his favorite surgery. And also, honestly, I enjoyed it very much recently. So I would like to tell you how was evaluation of our, let's say, strategy for stapedotomy. At the beginnings, I know it only from the history was the stapedectomy, mainly with the tantal, for example, wire. Then for many, many, many years, they were stapedotomies with platinum wire. And when I discussed honestly with Uwe Steinhardt, I would like to thank him for invitation today. We had a tough discussion about titanium. My father was not convinced, I was not enough experienced. That's what driven us for changing and for making more titanium prosthesis was the problems with the long process of the incus. So the platinum wire cut it, and there started to be not so many, but if there was too much crimped, there was another surgery which was not easy, because if you have necrosis of long process of the incus, if somebody did it, you know, they need to carve a little bit the prosthesis, you need to combine, so it's not easy. Other surgical procedure, I think, is like Professor Dazert very nicely presented, is endometal approach. I show you during the surgery. However, the issue, we do it always in the full anesthesia. We don't do the local. So I will show you that. And there are some conditions which are very, very important. And in each step, which I will show you during the 2 movies with MZAM, I would like to take some tips and tricks, which are, in general, they are important, and you can realize how important they are if you did some of stapedotomy. So the first, we need to clean the ear. We need to, of course, we make the typical Rosen cut, and don't make it too close to the tympanic membrane. Because if, for example, if you need to enlarge posterior wall too much, or you need to make better visualization of the oval window niche, sometimes you could have not enough flap. So don't make it too close, you know, 3-4 millimeters is better. And when you separate, when you elevate the flap, be very gentle and to take it fully, especially in the inferior part, because then you can have sometimes problems, and then the flap will be not in one size. So we need to separate it that. In some moments, if you have the bleeding, you could till you open the middle ear, you could use some adrenaline, and it could happen sometimes later if you are open. If you open the middle ear, so you separate and you do the entrance, then if there is bleeding, I prefer to use the dexamethasone solution. So this is very important to make it enough big to make later the proper opening. If we have the bleeding, you can see we have to enlarge, and this is very crucial moment, because later you could have complication. If you enlarge too much, the flap could go down and be intact with the long process of the incus and the piston. If you think about the drill at the beginning, I recommend to make the 1.0 bar, diamond bar. Later you will start to use 1.2 or 1.4. Why? Because if you have too large bar and you are not experienced, you could make the just the hole. You can make the flap, and you could make some entrance, and then you need to take some periosteum or perichondrium to make the meninoplasty. So opening of the middle ear should be at first enough large later, and remember it later, to crimp and to close the loop, because you could see sometimes the oval window, you could see the stapes, but then you could put even the forceps. You could see that there is some blocked from the with the dexamethasone, this one, for the bleeding. But going back to the hole, if you open it and you need to imagine that you need to make all the steps. You need to separate the chorda tympani. You could put the forceps, but sometimes it's too small later to crimp the loop, and then you are in big problem because then you can not enlarge so much. So we use the scissors, as you can see, to cut the posterior part, to take the stapes. I use sometimes laser earlier, but honestly, even the surgery was very good. Then there were some problems with tinnitus, so I think it made the middle ear too dry. So I stopped to use. I use always the scissor. I cut the posterior, and you need to be very careful to not immobilize the stapes foot plate, because then it will be more difficult to make the hole. Then is the suprastructure. You need to take the suprastructure to separate. Honestly, I separate it later. It's a little bit more tricky, but I separate it later. I prefer to have more robust stapes for the cutting procedure. And if you have a situation like that, always remember that some blood clot could be in the hypotympanum. So use the suction properly, and be careful and try to save the chorda tympani as much as possible, so not to attack it for so much. Then you need to see how is the situation. Absolutely, you need to be sure if you make that limited opening of the position of the facial nerve. It's not opened, if it's not problematic. So you see that there was opening, and there is also, we performed drilling with 0.6 diamond bar. Another important thing, sometimes that it's very small, carved in the bars, so they could dance a little bit. So you need to be sure that it doesn't dance. Always check the bar before you drill, not to make too big opening. Don't suck too close to the opening. If you need to suck, go from the promontory to clean it a little bit to know where you are, but don't suck it too much. If you suck, then you need to very fast put the dexamethasone solution, of course, and this is the issue. If you have the prosthesis first with the forceps, like Professor Dazert presented, and you need to put it in, and then with two tools with suction, then is 0.6 in general, or 0.8 suction, and with the hook you put it down. And then if you are sometimes not sure, if you have too much fluid, you need to see how is the size. I prefer in general 4.75, sometimes 5.0, rare 4.5. And quite often we adjust the loop. If we see that the long process of the incus is not normal, is sometimes thin, sometimes is thick, we can a little bit adjust the loop for that. If you make it too much open, then you need later too much crimping. So this is disadvantage. If you do it sometimes too thin, so then sometimes it could not go properly. Why we like and I like this thinner piston. I like it because I think that it will be better from necrosis point of view. It's much more delicate. I agree with that. Axis it's better for crimping. It's easier to do this, but if you are a little bit experienced, it could make it. This moment which you've seen is very, very crucial. The crimping of the prosthesis could make that you will make the luxation of the incus. From one of the cities in Poland is an enormous number of patients with luxation of the incus, and I'm very embarrassed to do the resurgery, because then there is a problematic how to do this. It's not easy to take out incus, but the luxation could be very often. So you need to, when you put the forceps to crimp that, you need to always imagine that you need to take it out smoothly. So that moment when you open the forceps and taking them out is the most crucial. We seal that with the blood clot, the tissue with the blood clot, and we would like to have blood clot over the loop. In our opinion, this is something what I really like. If the blood clot is not properly performed, and the absorption is that after 3-4 days, if the patient comes with some issue with some vestibular disorders, it could mean after 3-4 days that the blood clot was not enough big, and then you need to make a surgery, which doesn't happen often, but is the symptom if somebody has a patient somewhere that after 3-4 days after a stapedotomy is the problem. So this is that surgery, and the moment which could also lose your chance for good surgery, we take the fibrin glue, and you need to keep with suction the flap, because if you put the glue too much to the middle ear, then there could be some spikes after that. So let's repeat important steps in the second surgery. It's a little bit shorter than that one. So we have again the Rosencut. Then we need to really check how is the bleeding. I don't like to make, of course, absolutely no coagulation, not at all a situation like that. And that did this moment, if you see inferiorly, I like to open that more inferiorly, because if I don't do this properly here, it could mean that later there could be some rupture of the flap, and then we really need to play and never make it too close. It was one of the mistakes what I did at the beginning, that I make the cut too close. And in one case, I remember it was very difficult access, very difficult view, a little bit abnormality of the anterior wall of the external malleus, but the temporal mandibular joint was too close, and I didn't want to do any, canaloplasty. I made it too close, and then I had to take the perichondrium to make to close that, because the flap was too small. And the elevation is very important. You can see which tools we are using. Sometimes in that moment when we are, I like if you feel tired sometimes, because it looks very simple, very nice, 5 minutes. But if you feel tired in that moment, you could put the adrenaline, you could close the view, and you can relax your hands. Maybe you could laugh, but it's really worth it to have prepared hands for that. And you always need to remember that longer you do the surgery, you make that is dry of the chorda tympani. That case is more bleeding. You can see that it's a little bit. I said that it's dry coagulation with the diamond bar, so you can try to close it that with the drilling. And again, it's 1.4 diamond bar, but I earlier used 1.2 because I didn't want to make any hole in the flap. And you can see that I localize how is the situation, how is the incus. You should just sometimes adjust the view of microscope, never in one position. Sometimes I don't like the skitters. I tried some skitters earlier, but the skitters made the problems that sometimes the bar danced too much on and it could make you could make the mobilization of the foot plate, or something what I suffer from that is that some bone particles could go to the inner ear. So a regular strong diamond bar on the robust drill make you more stabilization, but then you need to a little bit play with the view. This is really, it takes some time to adjust, to have a good view and good work with the tools, because sometimes you can take fingers, into the microscope. In general, I always remember that the surgery looked very, very nice and very, very smooth. Later, there is several moments which could make that surgery will be not 10-15 minutes, which is as regular, but takes you sometimes and long story instead of short. If for some circumstances, for example, you will make hole to posterior, then this is my trick. Don't crimp loop too much, because if it will go in different direction and will be worse results. So if it happens, for example, that you will take the posterior cruise and it will hold there, then the crimping should be not too strong, because the direction of the piston will go on different side and will be hacking for the foot plate. If you make hole from the anterior side, then you need to take the piston also on a different side. And if you have different situation in the oval window, which for example is narrow, it happens that it's 0.8 sometimes, then check if there is some lip or overgrowth from the promontory, and you should make it more on the anterior side, which is quite risky. You always need to consider where to do the proper place, and not to make of course it's too anterior. And here you can see there was the cut. There is taking out of the. This moment is also very important because if you don't take it properly, you could make the luxation. Luxation is a very bad situation because this is the really problem. And the results from myelovestibulopexy, from some reasons, when you do some resurgeries, could be really problematic. This is important. You can see there could be some tissue. You need to be sure that you have a real foot plate if there is no tissue, because sometimes you can have tissue and then you can make wrong drilling. You can see how is the situation with the bar. It's a little bit dancing, but it's dancing because there was the water, it was fluid there, and it was a dexamethasone solution. And how to make the hole? The ideal situation is that you come close to the foot plate and to make high speed and go a little bit down and go up. It sounds easy, but it's not easy. But if you make too slow opening, too small drilling, then you will push the foot plate. It could happen that you will push the foot plate. So you need to make really quite fast drilling, and this is the matter of experience that you need to feel if you go properly. It's very often there are very tough foot plates. There are 0.5 millimeter. You could have some even 1 millimeter. Sometimes you can have very tough, very advanced sclerosis. Then they are problematic. Here there is the proper position of the piston. Then always, I don't want to crimp it too much, because if I crimp too much, and if happens sometimes, maybe in future that you need to take it out to uncrimp, that is extremely difficult. So you need to check how is the mobility, how it looks, and then you see that it works very well. In that moment, when we want to take blood clot, if you have too much fluid there, too much water, you need to suck it. So because if you don't suck it, you could have either some air or some fluid, and it could later be reflected with some vestibular issues. So there should be the dry area, and then the blood clot will be connected very well. And never use fat, please. Also another whole numbers of complications from 1 CT, 20 deaf people after the fat sealing, and this is disaster because we need to make them cochlear implantation. It's happy that that person is not in that place, but it was in 3 months a lot of deafness because fat sealing. So if you do the fat sealing, it could occur later in the deafness. So you can see how is the mobility, how is the situation in that delicate surgery is very delicate. It's very delicate piston. So if you don't feel comfortable, you could use like Professor Dazert, a little bit more safe for people who are less experienced. If you like more delicate surgery, you can do that. Both solutions are possible and are recommended. And I don't like nitinol, honestly. We don't use the nitinol pistons. We use that one like that. And this moment, which also, if you put it there, you see we control with the suction the flap. So the flap is not, it's smoothly, gently performance, and the dressing is taken out after in general 7 days, sometimes a little bit earlier, sometimes a little bit maximum 10 days, no longer for that. After a very important issue is to, I can see my, try to be more visible. A very important is to also to see after the surgery how is the Eustachius tube situation, if there is no sinus problems, if there is no inflammation from the sinus. So we sometimes put the inhalation on the steroids, the topical, to not to have problem with Eustachius tube, which could also be reflected in some problems with the middle ear. Thank you very much, and I open for questions and the discussion.
Thank you, Professor Skarzynski, for sharing your very, very valuable insights and tips and tricks for surgery. Please, to our audience again, if you have any questions, feel free to type them in the chat, and use this occasion to really get the experience from 2 very renowned surgeons. Also, I would like to mention that we have Uwe Steinhardt in the audience, who has more than 25 years or more than 20 years, let's put it like that, of experience in developing passive middle implants. So also, of course, you can tap his knowledge and get insights from him if you want. I don't see anything in the chat at the moment. Please, again, feel free to use this occasion. I do have a lot of questions actually for both of you. Well, first of all, I would be interested, since you both used very different designs of Stapes prosthesis. Professor Dazert, could you imagine, or would it be a possibility for you to use an M-SEM that Professor Skarzynski used? And Professor Skarzynski, would you use an M-axis, or are you really, is this your favorite prosthesis and you will stick to this?
Well, for me, I can say I can also imagine using a SEM Stapes prosthesis, because during the last 25 years, I used a lot of different prostheses actually. I prefer the titanium prosthesis, so this is my favorite material. And I like the M-axis prosthesis because of the wide and perforated band, because in my hands, it's nice and easy to position to the place where I want it. And I also have the feeling that the potential pressure to the long process of the incus to the mucosa is a little less if the pressure is directed to a broader wire area. So this is my personal view, but I could also imagine, of course, using the other prosthesis. And this shape was also used in the past, and with nice results, of course.
Thank you. So, Professor Skarzynski, would you ever try an M-axis?
Not yet. I tried similar, which is called a little bit different from different manufacturer, and the results were really, really good. And I tried it at the beginning, and the crimping was easier. Yeah, the crimping was easier and more safe. That's what I always like to do, to have as thin as possible with good results. I will see after many years. I don't expect it to be the problem. So I tried it, but I fully understand you as a company and other surgeons, if you do 10 Stapes prostheses per year, that maybe it could be a little bit too risky. So, you know, I don't only look for me, I look for others who are coming for the courses there. So at the beginning, I don't recommend to use MZAM. I recommend to use, you know, the axis, but after that, you can use the thinner. There was the question, how was the speed rate per minute? You know, 5,000 could be okay. I honestly, I don't look how is the rate per minute. I feel it in the speed of the opening. You need to make it fast. 15,000 could be enough. Don't go a little bit more, because then there's a noise. It's really noisy to make that reading, and and I will answer how I make that depth of insertion. If you want to check how will be depth of insertion of the piston. You put the piston of the foot plate before you push it to the hole, and then you see if it's 0.25 or 0.5 millimeter. If it's sometimes in malformation, it's not enough, and you see that, you know, the loop is going below that. So always if you do stapedotomy, have on the stock like 6 millimeter, for example, piston, because it happened 3 times in my experience that I have, you know, I think that everything is okay, but it was not typical otosclerosis, but it was malformation, and I had to model that. Okay, I answer. Now I'm hearing you.
Okay, thank you, Professor Skarzynski. Maybe also for you, Professor Dazert, how do you tell how deep the inserted Stapes prosthesis is in the inner ear?
Well, I'm using as a standard length of the prosthesis a 4.5 millimeter prosthesis in cases of otosclerosis. It may differ, as Piotr just said, if you encounter, let's say, middle ear malformation or things like this, then you may use a different length. But in Stapes, I usually don't measure. I use a 4.5 millimeter prosthesis, because the difference between incus and Stapes is pretty the same in the patients, even in different ages. And I checked by the microscope that the shaft of the prosthesis goes into the sapidotomy, so invades the vestibulum, so to say. I would say it's about 0.3, 0.4 millimeters maybe, but I make sure that it's inside and also deep enough inside, not, to jump out maybe during pressure changes in the middle ear and so on. Mm-hmm. So I visually control this area at the end of the surgery, and then I close with the connective tissue parts.
Okay, thank you. Do you also check that the piston enters in a perpendicular way, or how do you handle this situation? Because the piston should enter 90 degrees to the foot plate into the inner ear, ideally.
Yeah, that may be a problem if the stapedotomy in diameter is too small. Mm-hmm. So what I usually do is I choose a burr which is 0.2 millimeters larger than the diameter of the stapes piston. Mm-hmm. And by this, I make sure that there is no, that the stapes piston doesn't touch the area of the stapedotomy. Mm-hmm. If that is the case, I would widen the stapedotomy to make a clean movement possible.
Mm-hmm. Okay, thank you. So there is a question in the chat. Do you prefer standard size and diameter? We answered that. It happened to consider after surgery that the prosthesis is too long due to vestibular syndrome after surgery. So Professor Skarzynski, did you experience that?
Yeah, it's a very nice question. I remember when we had one dinner and we discussed 0.4, 0.5, 0.6 and others. Normally I try to do 0.5. I use the bar 0.6, and quite often even I use 0.6 is a little bit dancing, so it's the 0.7. So I agree with Professor Dazert, there is 0.2 is optimal. If sometimes I don't go fully with the bar, sometimes it's happened that I think that I'm in, but I'm not, then you could have a little bit smaller opening, and sometimes you could use the needle to open that. Then I use 0.4. And sometimes it could happen that, there is some broken of the foot plate, or sometimes could happen, so I then use 0.6. Very, very rare, but always I have in operation theater 0.4, 0.5, and 0.6. Preferable is 0.5. If, for example, there is some issue and I could not make it 90 degree because of some reasons, then I use 0.4. So even if there is not straight angle, that is not too much and it will be proper and I don't crimp it too much. Mm-hmm. There was the question in terms of vestibular disorders. If the patient is, awake, of course, there are some issue to say take some time, but when the next day morning still there is issue with vestibular problems, at the beginning, it could mean, and there was no problem with the bone dust or the, on the suction, it could mean that the prosthesis is too long. It could happen. So then there is revision, and then there is important to check. You could make the CT scan to check if there is no air. If you have air, that could be the problem, or if the prosthesis is too long. But that's why I like to use the blood clot and never underestimate the suction. If the piston is in, then I sucked a little bit with 0.6 suction with the distance from the piston. And if I have dry and I need to have fast to put the blood cloth, which is fresh blood cloth, fresh blood cloth. And it should be, especially in the anterior part, it should be surrounded. And this was the second question. And the next question, I think I could answer later because Professor Dazert also, I think, would like to tell something.
Mm-hmm.
Yeah, in terms of dizziness with a too long or potentially too long prosthesis, we check the patients post-operatively every day with the Frenzel glasses and the tuning fork. And a little dizziness is allowed in the first 2 or 3 days after surgery, as long as the tuning fork goes into the operated ear. I would not think about revision surgery, early revision. If the patient has really nystagmus and vomiting problems and stuff like this after the 2nd or 3rd day, and if the tuning fork changes to the contralateral side, then I would consider early revision. And in a case like this, I would probably remove the prosthesis, close the stapedotomy and wait for half a year and then go back if the patient has the wish for that.
Thank you. Professor Skarzynski, you already mentioned that you use blood cloth to close or to seal the stapedotomy. Professor Dazert, you use tissue. Which kind of tissue and from where do you take it, and why do you take tissue?
Well, I like the tissue, and this is taken from the entrance opening, from the end-oral approach area. You have to make sure that there is no squamous epithelium inside, because otherwise you produce cholesteatoma. And I like this tissue because it nicely adapts around the shaft of the prosthesis and still allows, like a rubber, the prosthesis to move, and still closes the perilymphatic fistula, which is made during surgery. In my view, there are different ways you can do this. You can use connective tissue, you can use blood clots as shown by Piotr. There are also surgeons who don't close it with anything, they just leave it as it is. In my opinion, the little connective tissue parts are pretty safe. They seal the area and still allow the prosthesis clean movement. So that's why I'm performing this, and this is my preference, so to say.
Thank you. Professor Skarzynski, I just saw you shaking your head about not closing the perforation. So I guess you wouldn't consider that.
You know, each school, if it's success, it's okay. But, you know, I've seen so many, trust me, so many deafness after not proper, I don't know why my screen is like in black. I'm not, it's so many cases were really problematic with the, maybe like that, with the deafness after not properly sealing. So even it was performed good, really many. It is, I think this year, last year we did 45 cochlear implantation after deafness after stapedotomies in other centers. It's quite a lot. And you know, it's always the issue later with facial nerve stimulator, with some ossification. I did it a lot. So, you know, this is my experience. So I'm really careful. Any material is okay. Tissue is also okay. It depends on the case. Fat and no material, really, please, if anybody would like to do this, I definitely not recommend to do this, because later it could be problematic, and sometimes that people are coming from some far away, and if they have some vertigo, some deafness, they in the COVID times they don't come to the doctor, and then could be the really problem. Also, the problem could be with too small size of the piston, like 0.4, and sometimes I've seen that somebody's using 1.0 diamond bar or 0.8. I review such work, and if you have big hole and if you make piston, then maybe it will be easier for you to put it to the hole, but later it's much easier and much faster could happen that it will be some problem. So it's I think both agree that 0 point is optimal, to not to make too large hole with too small prosthesis, because then it could also be the problem with the spikes. And the closing, the closing of that is very important, because I think the main reason of the resurgeries, they are problems because of the rhinosinusitis and the spikes after not proper closing of the flaps. It could happen that it would be some later spikes which you could take out.
I absolutely agree, and I do this in Stapes surgery, and I also do it in cochlear implantation. I also seal the area where the electrode goes through the round window niche, for instance. So I think it's not much work, and it just is a question of safety. With CI also. Yeah. With CI also, absolutely. Yeah. If you allow, Leni, I would like to make one comment in particular for those who want to start with ear surgery or with Stapes surgery. Independent what technique you follow, and Piotr said already there are different schools and different techniques, which is not a question of being better or worse, but if you start ear surgery, do it at least 100 times in the way your teacher tells you to do. Don't invent a new surgical technique after 5 stapedectomies. This is just not good. You have to find a standardized way, you have to train, you have to get experience. And if you did a lot of Stapes surgery, as you guys in your center do, in the World Hearing Center, this is amazing. 25,000 Stapes surgeries your father did, you said in the beginning. It's unbelievable for me. And but do it at least 100 times in the way you learn it in your hospital from your teacher, and then start to do variations. Very important in my view.
Yeah. So you understand how difficult it was for me to go at the beginning for that, you know, thinny titanium, which axis is better for the beginner. So I know why it's better and how it was difficult for the people who start. Really, and don't relax when you would like to make crimping. When I see and I talk with people who started and they want to learn more stapedotomy, and for the beginners, quite often they make mistake at the crimping of the prosthesis, and then there is luxation, and really because you are a little bit tired, hand is not as fresh, then you do and you take out too fast the forceps, and then there is luxation, and the success could then be the problem. And I fully agree. Not to invent too much, under you do plenty of surgeries, and then you could have a different view. Yeah.
For those people who don't like to crimp, or maybe do not have experience in this, there are also prostheses available which can be clipped over the long process of the incus. So that should be just mentioned to get a complete overview over the available prostheses. I personally like to crimp, and I like the feeling. I can, you know, give the crimping power with my hands, and but there are also people who don't like it, and they can use the clip, the fixed prosthesis, which are also available.
Yeah, if I make remark, if you make that click, please block with the suction the incus, because this is, we have one center who they're a fan of that. And then they make luxation, so they push it, and then there is luxation. So if you do this, is the way, of course, nice way for the people who wouldn't like. But then remember about the incus. Not do it with one tool, because then it could be problematic. This is my remark for that.
Thank you. And also one more question about the tympanoplasty surgery. So how was the learning curve, Professor Dazert, for the MX Pro kit?
Well, the learning curve was pretty steep, I would say. So I think the system is good for handling. It's easy to learn, and it's pretty straightforward if you produce let's say, your own length of the prosthesis. And I've had experience with different length variable systems, and that was pretty nice, in particular because you don't need special instruments. For other systems, you need certain instruments that are only for this type of prosthesis available. But here you can use your general microsurgical instruments, and this, in my view, is an advantage. And everything is together in one nice little package. You just open it, everything is available, and you go forward and do it. So I thought it was relatively easy to learn and easy to handle, and I like it.
Great to hear, thank you. So it is 4 o'clock already. If you still have time, we would have one more question. Would that be okay for the two of you?
Yeah.
Perfect.
Yeah.
Thank you. So it's about post-operative rehabilitation. What are your pros and cons for a Stapes surgery in combination with a hearing aid versus power Stapes, which means a Stapes plus a vibrant sound bridge in cases with larger sensorineural hearing loss? So what is your opinion on that?
I can tell it's important factor since 2 years. If there is bone conductive curve below 30 dB, I want to have in my agreement with patient written that the patient is aware that even after successful surgery, amplification could be not enough, and maybe there will be need for hearing aid. Because some patients after 10 years otosclerosis thought it will be surgery and will be super. And then I receive patient 50 dB bone conductive, 75 air conductive, and then they expect something. So I have in my quite often in the documentation, and I do like that. Surgery 7 days or 8 days after is taking out the tampons. We see how is the healing, and write in the paper after 3 to 5 weeks there is the visit with pure tone audiometry, and then there is the initial visit with hearing aid specialist. When Vibrant is super solution. I like the former version of OSB when you can more adjust the titanium tip, but it was not possible for the resonance. So we have now a little bit different coupling, but it's possible. And we consider Vibrant sandwich in the cases when there are some problems with external meatus. But honestly, bone conductive is not below 30-35 dB because of amplification. So if there is hearing aid not enough good working, or there are some problems with external meatus patients would like to do, there is enough space in the middle ear in the CT scan, then we can consider. And with Hamid Reza, we did a lot of trials with Vibrant sandwich, and we could do this. There is the issue of the space of the tympanic membrane, on the distance between the long process of the incus and the tympanic membrane. How do make everything adjusted? But is the solution? People expect more and more, and we don't. Even we do the perfect stapedotomy, sometimes it's not enough for them. So I think it's also good to know how is the option for that. Yeah, great question.
I absolutely agree with Piotr. So Stapes surgery plus conventional hearing aid works well. If it doesn't work, power stapes is an option. So stapedotomy and Vibrant sound bridge, for instance, on the short process of the incus. We have, I think, 3 or 4 cases in our department that work well, actually. But in our hands, it's not a standard procedure. It's very expensive. It's a sophisticated surgery. It's for special cases. But the hearing aid combination with otosclerosis patients, this is a standard procedure which is applied regularly, on a regular basis.
Perfect. Thank you so much for your expertise. So I don't see any more questions in the chat. Please, if something comes into your mind, always feel free to write your MED-EL representatives, and they will, of course, forward the questions to the responsible person. Thank you, Professor Dazert. Thank you, Professor Skarzynski, for your support and your valuable experience. It is really very much appreciated by me, of course, and also by the audience. I would like now to thank also the audience for joining, for participating, for asking questions, and would like to announce the topic of the next Surgery Online session, which will take place on the 30th of March, on the topic of cochlear implant revision surgery with Professor Joachim Müller from the LMU in Munich. So please don't forget to register for this session also, and I'm looking forward to seeing you all again very soon. Thank you and take care. Bye-bye.